Hey everyone, so today we're going to be talking about maxillomandibular fixation, which is basically to re-occlude the jaw due to a lower jaw fracture. So meaning that a fracture caused a malocclusion of the jaw, but most of the time the fracture is in the lower jaw, in the mandible. So there are two approaches to this, which is open and closed reduction. And the closed reduction is the use of wires and arch bars, which I'll talk about the arch bars in just a second. I'll explain that. But it basically is just wiring the jaw shut to help realign the teeth and the jaw for normal occlusion. There's not as much into this as there is for an open reduction. For example, you're not really going to drape, the prep is very minimal, whereas an open reduction is an open, clean case. So the open reduction is basically an ORIF, an open internal fixation of the jaw. And it's much more complex, so we will get more into that in just a little bit. But the arch bars, I'm going to explain that real quick. So those are just metal plates and wires that are used, like I said, to realign the teeth when a jaw fracture has occurred, and it helps occlude the jaw back to regain normal bite, alignment, and occlusion. The basic facial anatomy that you will need to know for this procedure is the mandible, which is the only movable bone of the face. It is a U-shaped and it suspends from the temporal bone. Teeth are embedded in the alveoli of the body of the mandible. And parts of the mandible include the coronoid process, the mandibular notch, mandibular condyle, ramus, mandibular foramen, angle, body, and alveolar process. The teeth that are embedded into the mandible are the incisors, canines, premolars, and molars. Now we will move on to the anatomy of the midface, which is composed of the ethmoid bone, the nasal bone, the zygomatic bone, and maxillary bones. The ethmoid bone is a complex bone and is part of the floor of the cranium, and it contains some of the sinus cavities. Then moving on to the nasal bone, which forms a bridge of the nose and articulates with the ethmoid and the maxilla. The zygomatic bone forms the lateral walls and floor of the bony orbit where the eyes are housed. The maxilla come together to form the upper jaw and anterior hard palate and a portion of the orbital cavities. The diagnostic exams that will be used prior to this procedure is X-ray or plain radiographs for simple fractures. And then computed tomography will be used if there is extensive swelling, and other imaging studies can be used. Preoperative testing that will be done is your basic CBC, CMP, diagnostic imaging, and testing of the organ's function. The type of anesthesia that will be used for this procedure is local or general, but local anesthetic with epinephrine is usually injected using either type of anesthetic. So even if you use general anesthesia, a local with epinephrine will most likely be injected. The positioning for this procedure, the table is usually turned 90 degrees to help the surgeon access the site better, but the patient will most likely be supine with the head slightly tilted backwards. Make sure that there is a padded headrest that is used with this. Semifallers with head tilted slightly backwards can also be used for this procedure. So the skin prep for the closed reduction would actually not require anything, except the surgeon may want male patients to be shaved. The skin prep for the open reduction, which is a clean procedure, would obviously be surgeon preference, but with whatever prep that the surgeon wants you to use, you will begin with the face, and it extends from the hairline to the shoulders and then down to the table sides. Draping for the closed reduction is actually not required either, but some surgeons like to place some kind of draping down, and sometimes we'll use the same draping as the open reduction that we're going to talk about in a second, but it's not required. For an open reduction, the patient is draped with a head drape and a drape sheet, and then 2 towels under the head, with 1 towel wrapped around the head and clipped with a towel clip. And then a split or a U-drape will go over the patient's body. The equipment and supplies needed for this case for a closed reduction would be, of course, the padded gel headrest, extremity restraints, but make sure that they are padded, suction, local anesthetic, and a small basin. For open reduction, the equipment and supplies needed would be an ESU high-speed power source for your power drill, a basin, 2 number 15 blades, a drain such as a Penrose drain, and fiber optic headlight and light source. The instrumentation for the closed reduction would include a bite block, a bayonet forceps, a Weeder tongue depressor, a freer septal elevator, a probe, wire cutters, a wire twister, a caliper, arch bars, latex bands, and stainless steel wires. For an open reduction, you'll need a minor ortho tray, an ESU bipolar bayonet forceps, bone graft instruments, a Weeder tongue depressor, bone holding clamps, a high-speed drill, the depth gauge for the drill, a caliper, compression plates, arch bars, latex bands, or stainless steel wires, as well as a nerve stimulator. Okay, so now on to the actual procedure steps. So these are both very simple to understand, and the closed reduction is very straightforward, to the point, and simple. So like I said, the open is basically just the wiring and the use of arch bars to regain normal bite pattern and to reocclude the jaw and teeth. So first, when you get your arch bar, you're going to want to bend it to conform to your teeth and the natural dental arch of the patient. And so then first, before applying the arch bars, there will be a fine wire that is used that encircles around the neck of the teeth, and that is then used with the bars and stainless steel wires to attach to the teeth. And maxillary and mandibular arch bars may be used to set the jaw. Then finally, you're just going to take wires or latex bands and attach them to the arch bars, and this will give your final occlusion of the jaws. So now we're going to talk about open reduction. So this one is much more complex, but still very simple to understand. And it is used for more complex fractures or unstable fractures, or more into the midface, as well as the jaw. So first, you're going to inject your local anesthetic. Then you are going to make an incision into the mucosa, which is below the inferior border of the mandible. Then you will expose the fracture site, remove the periosteum, and then you may have to use manipulation to reduce the fracture. Compression plates and screws or arch bars may be used prior to this to externally occlude the jaws. So for example, if the surgeon decides he wants to use open reduction, then he may do a closed reduction modified first and then do open. So then, at the fracture site on either side of the mandible, holes are then drilled in order to place the screws of the arch bars and the jaw. So some more experienced surgeons that have been doing a lot of these may use lag screws to compress the bone on either sides of the fracture. Finally, another way to stabilize the fracture would be using bone clips or a bone graft. This is all surgeon preference and what they feel comfortable with, whether it's the bone clips, the bone graft, the lag screws, or the stainless steel wires and bars and screws. So this mostly will be used with the wires and arch bars and screws. That's what most surgeons will use, but like I said, it's just preference and what they're comfortable with. But once the occlusion and alignment and stabilization of the fracture is achieved, we will then irrigate the wound, close all the layers, and then most likely a surgeon will place a drain to help with any bleeding or drainage that may occur.